But yeah, right now we're going to just take a couple of minutes so people can catch their breath, answer maybe a couple of these questions that we're putting up on the screen. And if I could just ask the other two panelists, Doctors Chauhan and El Khoury, to come on screen. And in the next couple of minutes, we'll just get started with our afternoon Q&A. Yes, thank you all. We're going to just give folks a minute or two to catch their breath and maybe take a comfort break, and then we'll get into the afternoon Q&A.
Good to see you, Dr. Bushnell, Dr. El Khoury. Good meeting both of you.
Yeah, nice to see you guys. Wow, what a great set of slides you want. And I apologize. Help me with your name, Dr. El Khoury.
El Khoury, yes.
El Khoury. Yeah, El Khoury.
Hi.
Very nice to meet you, Dr. Bushnell.
Nice to meet you. I gotta apologize. You had such a great presentation.
Oh no, yours is amazing too. I have to say that.
Well, I'm looking at your slides and I'm thinking, these are really great slides.
Thank you.
And I'm thinking, wow, I really would like one or two of these slides. And so I said, well, no, you gotta.
I'll be happy to share with you, Dr. Bushnell, if you want. Absolutely.
Well, it's very kind, and I'm going to take you up on that. But I'm trying to get to my confession here. I was on my screen, and I went to your first slide because I wanted to get your name correct.
Oh, okay.
I clicked on that slide, and I'm mortified because it shot you back to the beginning.
That was fine. It's like that was fine. Totally fine.
Oh, all right. Well, Dr. Chauhan, are you ready to moderate this lively group?
Yes, sir. Yes, I think we're ready. By the way, Dr. Bushnell, Dr. El Khoury, she does all our neuroendocrine tumor boards. She's a pro at creating images and reading images, and I mean, we can't function without her. She's the most critical component of our neuroendocrine tumor board.
Thank you so much. I really appreciate it.
That's fabulous. Very nice to meet you.
Yeah, very nice to meet you. And I love your passion about. I mean, I share the same passion toward nuclear medicine, and I really enjoyed your talk a lot.
Thank you.
And I have to admit, I took some snapshots. I have to admit.
All right, guys. Well, welcome back, everybody. And I think that was a fantastic session by both our excellent nuclear medicine specialists, Dr. Bushnell, Dr. El Khoury. And now to the most interesting and the concluding session, which is the Q&A session, where we go over some of really interesting questions you guys have been sending. And again, my name is Aman Chauhan from University of Kentucky. And the first question, okay. Want to clarify that a gallium-68 dotatate scan has less radiation exposure than a routine CT scan. Riham, why don't you go ahead with that question? Radiation exposure of a gallium dotatate scan as compared to a conventional CT scan.
I don't think I can answer that on the top of my head. We compared the gallium dotatate to the indium, and actually when I did, I went back to my radiation safety physicist to do that because I really like to give accurate information to our patients. And I knew that gallium-68 just by characteristics, because of the very short half-life, it's going to be lower radiation, but the number I presented was actually what our radiation safety physicist calculated for me based on the standard doses. So I would be happy to share that. Dr. Bushnell, if you know the answer to this,
Dr. Bushnell, you have a comment on this?
Well, so a gallium PET CT, we typically do non-contrast. Now, some people do contrast CT with the gallium PET, but most would say non-contrast compared to a 3-phase CT scan. I believe you'll find the whole body radiation dose is a little bit lower with a gallium non-contrast CT compared to a 3-phase CT, but I think a non-contrast whole body CT and the gallium portion of the PET CT have actually sort of similar amounts of radiation.
Okay. Well, that's good to know. Well, one thing we can say for sure, gallium dotatate scans less radiation as compared to the older Octrio scan. where the CT scan, it's not a fair comparison, as Dr. Bushnell said, because there are different types and protocols of CT scan we use. We use a different amount of radiation and contrast for, let's suppose, the triple phase liver versus another scan. So would not be an easy and accurate answer. All right,
Can I add
moving
something,
on.
Aman, if you don't mind? Just one
Yes.
second. Well, I understand all the all the people freaking out from radiation, but you have to always remember that the contrast CT or MRI gives a different kind of information that what we do with our molecular imaging. So we cannot replace each other. This is why actually University of Kentucky, what we do is we alternate every 6 months a CT, and then the next 6 months is a dotatate. So we don't do them in the same setting, yes, but I don't want you guys to take the wrong impression that we want you to replace all the contrast CT with the dotatate, because we just simply cannot do that. It's a totally different kind of information you get with the contrast CT. I just wanted to make sure that, yeah, this is clear.
Could not agree more. All right, moving on to the next question. Everybody's heard about this new scan, which is coming now, FDA approved, called DetectNet. So somebody asked me a question about, is it the same type of scan? Do we use the same machine, or is it simply a different type of injection? Dr. Bushnell.
Well, and I know Dr. El-Khouly talked about this, and I think you showed some slides, so I'll quickly defer to you. There is one head-to-head study between copper-64 Tate and gallium that I'm aware of. So my recollection is the results are quite comparable, but I'll ask Dr. El-Khouly, what's your thoughts about the relative value of one versus the other?
I think I agree totally with you, Dr. Bushnell. I think they are comparable to each other. I think technically or like characteristically, the copper-64 positron energy is smaller, which we think it will result in a little bit of better resolution, less misregistration that we face with the gallium-68 dotatate, which we can deal with totally. It's not compromising our ability to diagnose with the gallium-68 dotatate. I think the key advantage of the copper is going to be the availability. Just the fact that it's 13 hours half-life versus 1 hour half-life, and that it's a cyclotron produced. So it can be like FDG. It's going to be as available as FDG. Any cyclotron can produce it, and it can ship 3, 4, 5 hours away like what we do now. While gallium-68, it has been always the generator was the limitation. You have to have a generator in your area, otherwise you cannot provide. Because if you have a generator 4 hours away with 1 hour half-life, you have to produce a big dose to be able to ship it and reach and be injected in the right, correct standard dose. So my opinion, we don't have a lot of like personal experience with that. We are in the process of getting it approved internally, and we hope that by the beginning of 2021, we will be like in January, February, we will be able to offer it, and we will do that in our institution. But my impression so far from the scanty literature is that it's comparable to gallium-68 dotatate. It's just going to be more available. This is my own opinion.
Dr. El-Khouly, just to a follow-up question to that, logistically for a patient, what are the differences in terms of number of injections, wait period? What would be the key differences between gallium-68 dotatate scan versus the copper scan?
My impression is that there's not much difference. The studies have shown that maybe the image quality is going to be better after 2 hours or 3 hours, but I think logistically, which we do a lot, like for example, the FDG, the best uptake is usually 90 minutes, which I think some centers in Europe do 90 minutes uptake, but for logistic reasons, we do 1 hour in the United States. So I'm guessing that to make it easier here, it's going to be the same logistic as gallium dotatate. I don't know, Dr. Bushnell, do you have a different impression about this?
I don't know. I think you make an excellent point. You can potentially image out 2, 3, 4 hours, and maybe the uptake will be a little better in the tumor at that point in time, but you have to balance that against the disadvantage of the logistics for patients in the clinic.
Excellent. There's another interesting question from one of our participants. Gallium-68 dotatate scan, is this a new standard of care for all neuroendocrine tumors, or are there some subtype of NETs which it will not work on? Dr. Bushnell, and then I know Reham has some interesting viewpoint on this too.
Gallium-68, works very well, I think, for almost all neuroendocrine tumors. Now, the one exception I'm interested to hear as well, the bronchial carcinoids don't, especially the typical bronchial carcinoids, seem not to express somatostatin receptor. Maybe the atypical more. I'm interested to hear what you think about the receptor expression in those two. But I'll turn it over to you. I think you probably have a better sense.
Riham, your microphone is switched off.
I'm sorry. I tried. I just want to decrease the noise, so I would switch it off when I'm not talking. So generally, we have to understand that neuroendocrine neoplasm is a big family that has well-differentiated low grades, grade 1 and 2, and we have the fully differentiated neuroendocrine carcinoma, the small cell, the large cell, and the mixed. These dotatate doesn't do well with these, and we don't even request dotatate for these. So small cell, large cell, we do FDG, straight FDG. We don't do dotatate at all. Dotatate performs well with the low-grade, well-differentiated neuroendocrine tumor. And we know that there are certain subtypes of even low-grade, well-differentiated, like insulinoma, for example, is known to poorly express somatostatin receptors. Bronchial has variable. We had cases with beautiful somatostatin uptake on dotatate with bronchial. And some other cases, yeah, we face this. I just had a case yesterday. I was reading PET-CT, and it's bronchial, it's pulmonary, and it's proven well differentiated low grade. And we do the dotatate, and I had an FDG from outside study like a month ago. So it's beautiful comparison. But it didn't take much from FDG. It's like very mildly avid with dotatate, which is this. We know that some bronchials absolutely they don't express as much dotatate, especially when you were talking about smaller lesions.
What's your do you have a feeling about Pentixafor, CXCR4 for the higher grade tumors?
I actually don't have any experience with it. I would love to hear from you, Dr. Bushnell, because your image was beautiful, the image you showed to us.
Yeah, I'm a strong believer. You know Yusuf Menda at the University of Iowa. I'm sure. Anyway, he's been doing the work, and if you're interested, he'd be a great contact.
Absolutely, I would love to get in contact with them. And actually, it's going to be a beautiful target because FDG it shows beautiful uptake, but it's not a good target for any therapy. This is the problem, the limitation with FDG avid disease is that we cannot use it as theranostics, right? We're limited. But with the images you showed, I think it's a very potential for theranostics as well.
Correct. Yeah. And just a small plug here, I would like to mention that last month, NCAN awarded me with a large grant, close to $80,000 US, to help study somatostatin receptor expression in higher grade neuroendocrine cancer. There are some publications, but they're retrospective, though clear prospective. So what we are doing at Markey Cancer Center, we are using that grant to study large cell neuroendocrine cancer, which is a subtype of high-grade neuroendocrine carcinoma. And we know from previous retrospective data, 20 to 50% of these high-grade neuroendocrine cancer can be somatostatin receptor positive, making a case for using targeted radiotherapy for these high-grade cancer patients. So again, very grateful for NCAN to support our research and in high grades. Next question is, I think it's for me. The question is, what is M3814? So I briefly mentioned about M3814 plus Lutathera phase 1 clinical trial, which just got approval for funding from NCI and also from Merck KGaA, the German Merck, also known as EMD Serono in the US. This is a novel DNA PK inhibitor. Dr. Bushnell was alluding to PARP inhibitor, how that can affect the DNA repair process after we cause DNA damage with radiation. This is kind of leveraging the similar concept. Lutetium-177 dotatate, Lutathera, is a great anti-cancer drug because it causes either single or double-strand DNA nicks and causes tumor cell death. But most patients eventually would see the tumor would grow again. PFS 30, 35 months. But most patients would eventually regrow the tumors. Why is that? Because the DNA has a really good capability or capacity to repair itself. M3814 is a DNA PK inhibitor, which which efficiently targets this DNA repair process once we cause this damage. We had some really good data in the mouse models, which we presented at Boston NANETS. And based on our promising data, we have now almost at the cusp of launching this phase 1 study, which would be a multi-center study, and I'm hoping would be open throughout 20 to 25 centers in the US, and we are the lead site for it. Next question is, Lutis, I guess this is also for me. The question is, Teletrostat plus lutetium phase 2 study, is it only limited for functional neuroendocrine tumor? It's a good question. The rationale for us to combine Teletrostat with lutetium in our phase 2 study was not just to focus on syndromic patient. We believe Teletrostat has anti-tumor effect in all neuroendocrine tumors. In fact, let me tell you, there is an ongoing phase 3 trial using Teletrostat in combination with chemotherapy in gallbladder cancer, which is a much more aggressive tumor. So there is a rationale for antineoplastic activity. Neuroendocrine tumors, regardless of functional or non-functional neuroendocrine tumor, we know from preclinical data that serotonin tends to affect the tumor growth. And if we can cut down the serotonin production in the neuroendocrine tumors, we believe that will add to the cytostatic effect of Teletrostat. And that was the rationale behind using Teletrostat. We know from Telestar study that higher dose of Teletrostat was able to reduce serotonin breakdown product 5-HIAA much better than the currently used dose. So we are testing 2 different doses and kind of go from there. Somebody asked, looks like we have a member attending from outside the US. Somebody's asking, are there specialists, neuroendocrine tumor specialists in Portugal? Now, we do have a very good resource to find NET specialists in the US. Carcinoid Cancer Foundation has a list, and some other websites also have a really nice list based on sites. I'm not 100% sure if we have a similar list for European colleagues. However, I'm part of a group called NET Connect. So if you Google Meet netconnect.com or .org, you'll find a group of 30 neuroendocrine tumor researchers from all over the Europe, Asia. Me and Dr. Bergland from US are there. So I could find that Spain is very close to Portugal. And I know Dr. Capdevila at Vall d'Hebron, he is really leading authority in neuroendocrine tumors, and he's right across. So you can have a quick car trip to Barcelona and see Dr. Capdevila. He is really well known, and I know has a lot of clinical trials open in Barcelona. So that's probably the closest NET specialist that I can guide you. We have another fresh batch of questions. Let's move ahead. Any additional advances or insights for kidney protection with the current amino acids during PRRT? And for those patients with reduced kidney function, do we have enough information yet about half dose or fewer treatments of PRRT? Dr. Alkhouli, you start off, and then I'd like to also hear Dr. Bushnell's thought process.
Yeah, absolutely. Well, we really have been treating with PRRT since 2018, and we treated many patients, and amino acid is doing a great job with kidney protection. I always look at when we approve, because we do 4 doses for each patient, we always look at the standard platelet counts, the liver functions, renal functions. They're really, really very good, and I think the amino acid is great. We do give half doses already when we find the functions, but usually is the platelet. What we see that is affected is mostly the marrow, right? We see the platelets dipping down, and sometimes it doesn't recover as fast as we would like it to do. We have 2 options. Either we can delay the next cycle for another 4 or 8 weeks and wait for the marrow to recover, or we can just give half dose, and we do that. We do give half doses and watch again, and it's like an interactive treatment. Yeah, it's a standard 200 flat dose we give. This is the FDA approved dosage, but we do change that according to patient per patient. I'm saying I don't, Dr. Bushnell, do you have any insight about somebody with the renal compromise?
Well, I'm glad you mentioned the potential for hematologic toxicity, which is greater because of the reduced clearance of the radioactive drug. So I'll tell you what our approach is. We do treat patients with varying degrees of renal insufficiency all the way down to dialysis. We treat patients potentially on dialysis. We take a dosimetric approach, and what we do is, because the exposure is going to be potentially greater to kidney and marrow, we will measure the dose for the individual patient that we'd expect to the kidney from the 200 millicurie or 100 millicurie, and measure the marrow as well dose, and then we limit the exposure to those two organs, and then treat based on that limit. So for example, we'll treat up to, we usually kind of stay around 2 gray for a kidney from when you have renal insufficiency, because it already has some compromise. And then we actually try to keep the individual cycle dose down pretty low to the bone marrow, to even 50 centigrade kind of thing.
May I ask a question? Do you guys use a trace dose of lutetium-177, or what do you use for your dosimetry assessment?
Yeah, well, up till now, we've used, in the past, we've used Octreoscan. So it's not perfect, but we've used that primarily for patients on dialysis. The few that we've done, we've used Octreoscan. But then more recently, our approach is to go ahead and give the first cycle of Lutathera as 100 millicuries, and then do the dosimetry from the 100 millicurie administration. And then the next cycle, and the next cycles are tailored, to the measurements made off of that first 100 millicurie cycle.
That makes a lot of sense. And do you mind if I ask how many imaging do you do? How many time points?
It's a great question. I showed the slide. We really are pretty convinced that the single time point is adequate for kidney dosimetry. The problem is there's not much data for bone marrow dosimetry on single time point. So we have to date continued to get multiple 4, 24, 48-hour images because of the bone marrow measurement, more so than the kidney.
All right. Looks like the questions are trickling in, but I agree with both the nuclear medicine specialists. Our experience, especially with the kidneys, with Lutathera, that's very renally safe, at least in normal patients. It is a very important question which is yet to be answered in a good prospective manner, that the renally compromised patient, how safe it is, because often these patients are not included in clinical trials. So it's really important to have smart nuclear medicine docs like these two to kind of have those discussions and evaluate individual risk and benefit and make the final call. The next question is regarding, should cardiologists be involved as a part of core team while dealing with neuroendocrine tumor patients? We have had a little discussion today about the potential impact of NETs on heart valves and need diagnostic testing, etc. So first of all, I would like to caution that the panel here would just answer general educational pointers, and please do not consider this as medical advice. We are not allowed to give individual patient medical advice. I think being a medical oncologist, let me weigh in. There is a condition called, about 30% of neuroendocrine tumors can be what we call functional neuroendocrine tumor, that they secrete certain hormones, and the most common one is serotonin. And if the serotonin level is quite high, it can have deleterious effects on various organs, especially heart, which is called carcinoid heart syndrome, wherein the right side of the heart valve, which is tricuspid valve, gets completely destroyed, which can lead to right-sided heart failure. So if there is a patient with elevated serotonin level, we definitely like to monitor their serotonin closely, evaluate their heart functions with the help of echocardiogram. And if there is changes noted in their valvular function or their ejection fraction or the way their heart's squeezing, we like to get cardiologists involved in the care, because this is a very important and serious condition which cannot be reversed when it happened. So the best thing is to prevent it. The way we prevent it is by lowering the serotonin. However, having said that, should every patient get evaluation for heart and subsequent monitoring? I would not say so, because if somebody has non-functional neuroendocrine tumor, then they are not at the risk of developing carcinoid heart disease. So it depends on individual patient. Moving forward, should patients expect a similar monitoring schedule with copper-64 scan versus gallium-68 scan? Riham.
I think they're similar, yeah, the same, I think, schedule. I don't think the only difference, so the biological part, which is the dotatate, is exactly the same. The only difference is the radio label or the attached radioisotope that we can see with our cameras. So biologically, we will just follow it based on the biological behavior of the disease, not based on the used radiopharmaceutical.
Sounds good. Will radiologists need to take additional training to read copper scan? Dr. Bushnell.
Dr. Chauhan, can we do one more question, if you don't mind?
Oh, okay. Sounds good. Let me see if I find something really, really interesting or which we haven't answered yet. Okay, let's do this. Since we have two gurus, nuclear medicine gurus with us, can we give more than 4 rounds of PRRT later down the road for progression? And what kind of data do we have to support that? Dr. Bushnell, you go first, followed by Dr. Alkhouli, and we'll call it a wrap.
So yeah, there is a small amount of published data to support pretty good safety and efficacy. If the first round has if the patient responds to the first round, but then later on, months, years later, the tumor recurs, there's some retrospective data that suggests pretty good response and a little higher toxicity, but not dramatically so. Our approach has been, if the individual has responded to an initial round, usually 4 cycles, we go ahead, and assuming that the blood counts, lab counts, and so forth look good, and that the tumor continues to show targeting based on the gallium dotatate scan, we typically go, and usually based on what's been published, 2 cycles. Typically 2 cycles is the approach we take.
Gotcha. Riham, you agree or disagree?
Yeah, no, absolutely. I totally agree with Dr. Bushnell.
Fantastic. And I'll take liberty to ask one last question. Sorry, Bob. I think this is a pretty interesting question. So PRRT second line or third line? Dr. Bushnell, what's your answer? Riham, what's your answer?
Oh, first line.
First line?
Dr. Alkhouli,
We're biased. Yeah, we are biased groups.
We are biased.
Yeah.
Thank you.
Maybe you should answer this question.
Yeah,
I mean, you'll be more.
Well,
yeah.
I'm kind of biased too, because I'm leading 3 or 4 PRRT studies. However, having said that, we do have some data coming from Europe that PRRT responses are superior when used earlier as compared to when used in refractory setting. However, with the caveat, these are retrospective data. And also, when you use treatment earlier, patients respond better with any therapies. That's because the disease become more refractory down the road. So it needs to be tested in prospective manner. We have a phase 3 trial going on, which is called COMPETE phase 3 trial, which is comparing Afinitor versus PRRT. And that, I think, would answer this question once and for all. With that, I would like to thank the panelists. Wonderful, wonderful discussion. Thank you, all the participants, for sending lovely questions. I'm sorry we couldn't cover everything. And Bob, over to you. Thank you for this lovely opportunity.
Yes,
thank you so much.
Yeah. Great panel. I always wish we could run for hours and hours, and we have, and people will sit in their seats for the whole thing, but we do need to end at some point. So thank you again.
Absolutely.